You usually think of a bathroom break as like the most mundane part of the day. I mean, for most people, it operates purely on autopilot. You go in, you do your business, you wash your hands, and you leave.
Right, yeah, you don't give it a second thought. It's just the definition of a routine biological function. Your body just handles the logistics in the background.
Exactly. But imagine if that unavoidable daily act felt like navigating an actual minefield. Picture a scenario where something as basic as passing a bowel movement required, strategic planning, specialized equipment, and just this very real anticipation of excruciating pain.
Oh, absolutely. I mean, that level of anticipation changes the entire landscape of your day. It
Mhm.
completely dictates what you eat, when you feel safe leaving the
Yeah,
house.
your baseline anxiety just goes through the roof.
Exactly.
And that reality is the focus of our deep dive today. We're taking a really highly specific look at how clinicians manage bowel movement-induced perianal tearing in a condition called lichen sclerosus, or LS.
And we're pulling all our insights today from a really comprehensive stack of medical literature. We're looking at the European and British Dermatological Clinical Guidelines, the BHH National Guidelines, and Pediatric Health Info.
Yeah, from places like the Royal Children's Hospital, plus some specialized patient care leaflets from various health trusts. So, okay, let's unpack this. Our mission today is to map out the patient's journey to a pain-free bathroom visit.
Because managing this isn't just about handing someone a pill, right?
No, not at all. It requires fundamentally redesigning how we approach a basic bodily function. And to understand why such a radical redesign is necessary, we have to look at what lichen sclerosus actually does to the skin.
Right, because it's not just a rash.
No, it fundamentally alters the architecture of the tissue.
Hmm.
The medical literature describes this distinct visual progression. It often begins as these flat, ivory-colored spots.
And over time, if that inflammation is left unchecked, those spots merge together. They form these crinkly, thin patches. The standard clinical term used across all the guidelines to describe the texture of this affected skin is, they call it cigarette paper.
Oh, wow. Cigarette paper immediately gives you like a visceral sense of the fragility we're talking about here.
It is a devastatingly accurate description. I mean, the skin completely loses its elasticity and its robust barrier function. It becomes up to 10 to 15 times more fragile than healthy, normal skin.
That is just wild to think about.
Yeah, and there is a fascinating anatomical boundary noted in the guidelines that we really have to establish early on. While LS heavily affects the perianal skin, so the skin on the outside surrounding the anus, it never actually goes inside the anal canal itself.
Wait, really? It just stops.
It marches right up to the mucosal border, the transitional line where the outer skin meets the inner tissue, and it just stops dead.
That is such a bizarre disease quirk. It's almost like there's an invisible force field at the mucosal line or something. We definitely need to come back to that mystery later.
We will, for sure.
But for now, if we focus on this cigarette paper skin situated right at the exit point, I mean, I can see where the sheer mechanics of a bowel movement become a physical nightmare.
Oh, absolutely. Let's walk through the clinical cycle of what happens, because the pediatric sources highlight how quickly this spirals, particularly for children and young girls.
Right.
You have this incredibly fragile skin. A bowel movement occurs, the tissue simply cannot stretch to accommodate it, and the skin tears. It literally splits open.
Which obviously causes intense pain. I mean, it has to.
Agonizing, sharp pain. And we have to consider what the human brain does when an action causes agonizing pain. It avoids the action.
Yeah, basic survival instinct.
Exactly. This leads to a profound psychological fear of passing stools, which translates directly into physical withholding. A child, or even an adult, really will consciously or subconsciously clench and hold the stool in.
But the digestive system doesn't just pause, right? Like, the colon is still doing its job.
Right, the colon continues doing its primary job, which is absorbing water from that stool.
So the stool is just sitting there in the colon, drying out, getting harder, larger, and more compacted by the hour.
And when the body finally reaches a point where it just cannot withhold any longer, you are now forcing a much harder, larger mass through skin that is already torn and compromised.
Man, it is essentially like having a paper cut on a rubber band.
Yeah.
And you are forced to stretch that rubber band to its absolute limit every single day.
That is a perfect analogy.
How does the skin ever actually get a chance to heal if the trauma is a daily occurrence? You're just ripping open the same wound over and over.
That's the tragic physical reality. And the dermatological guidelines introduce a biological concept here that makes this cycle even more insidious. It's called the Koebner phenomenon.
The Koebner phenomenon. Yeah, I saw that term in the guidelines, but how does that actually work in practice?
Well, it describes a process where mechanical physical trauma like a tear, a split, or even intense scratching actively triggers new lichen sclerosus lesions to form.
Wait, in previously normal skin.
Yes, in previously normal, healthy-looking skin nearby.
Wait, so the tearing isn't merely a painful consequence of having the disease. The tearing itself is actively spreading the disease to new tissue.
That is the pivotal realization here, yeah. The mechanical trauma is an active driver of the disease worsening.
Oh, wow.
When the skin splits, the body's inflammatory response rushes to the site of the trauma to heal the wound. But because of the underlying autoimmune nature of LS, that healing process is hijacked.
So it builds the wrong kind of tissue.
Exactly. Instead of building healthy scar tissue, that localized inflammation manifests as brand new, diseased LS tissue.
So stopping the tearing isn't just about, providing the patient with pain relief. It is literally about stopping the disease from claiming more territory on the body.
Spot on. Because of the Koebner phenomenon, a clinician's absolute first priority is breaking that cycle of physical trauma. You have to mechanically protect the area to stop the spreading.
And this brings us to the patient leaflets in our sources, which honestly read less like standard medical advice and more like a tactical manual for navigating the toilet.
They really do.
I was genuinely intrigued by the highly specific bathroom hacks they detail. Because if tearing spreads the disease, the first step obviously has to be mechanical protection.
Well, foundational advice always applies, of course. The guidelines stress hydration, a high-fiber diet, and clinicians will frequently prescribe daily laxatives to ensure the stool remains soft. You absolutely have to fix the internal payload first.
Right, soften the cargo so it doesn't cause as much strain. But what surprised me most wasn't the diet advice, it was the strict rules about managing the actual exit site.
Oh yeah, the pre-care is crucial.
The sources recommend applying a thick barrier emollient, things like yellow, soft paraffin, Vaseline, or an aqueous cream directly to the perianal area before passing a bowel movement.
It is a highly effective mechanical workaround. By applying that ointment beforehand, you are artificially providing the lubrication and the structural protection that the diseased skin is currently lacking.
Makes sense.
It eases the friction of the stool passing, and it creates a physical, waterproof shield against the highly irritating digestive enzymes that are naturally present in feces.
Now, here's where it gets really interesting to me. The section on the actual cleanup was eye-opening. Traditional dry toilet paper is essentially the enemy in this scenario.
Total enemy. Standard toilet paper acts like sandpaper against cigarette paper skin. It guarantees microabrasions, which, as we just discussed with the Koebner phenomenon,
Triggers more disease.
exactly.
So the sources suggest radically redesigning how you wipe. First, if you must use paper, they recommend sourcing unbleached, chemical-free toilet paper made from recycled or bamboo fibers.
Right.
But even then, they explicitly say to apply a dollop of aqueous cream directly onto the toilet tissue before it touches your body.
Yeah, that eliminates the dry, scratchy friction. You are gliding the moisture across the skin rather than scraping dry paper over an open wound.
Some leaflets suggest ditching paper entirely and using gentle cotton pads moistened with just plain tap water. And they issue a massive warning against those commercial wet wipes you see in the supermarket.
Those commercial wipes are a disaster for LS patients. They are loaded with preservatives, synthetic fragrances, and harsh chemicals designed for long shelf lives.
Just a chemical soup.
Basically, applying those to already compromised, inflamed skin can trigger severe contact dermatitis.
Now, the ultimate hack they recommend, which seems to bypass all the friction issues entirely, is using a peri bottle.
Yes, the peri bottle is a fundamental tool for this condition. It's a small, handheld squirt bottle designed with an angled, long nozzle.
Like the ones they give you at the hospital after you have a baby.
Exactly the same thing. You fill it with warm water and use a gentle, continuous stream to clean the area. There is zero friction, zero wiping, and therefore zero mechanical trauma to the skin.
It is such a simple intervention. But if you're trapped in that cycle of tearing, it has to be revolutionary. Oh, and I have to mention this one incredibly specific tip from the Royal Berkshire Hospital leaflet.
The fridge hack.
Yes, they suggest keeping a tub of aqueous cream in the refrigerator. When the skin is actively inflamed, burning, or itching, you take that fridge-cooled cream and you dab it. They are very clear. Dab, do not rub onto the sensitive skin.
It's fantastic advice.
Just, make sure you label that tub clearly so your family doesn't mistake it for mayonnaise when they're making a sandwich.
Yeah, that would be an unfortunate mix-up. But really, it's a brilliant at-home remedy because it acts as an immediate, localized anti-inflammatory.
Because of the cold.
Right. The cold constricts the blood vessels slightly, which reduces the heat, the swelling, and the itch, all without causing any mechanical damage to the tissue.
That's so smart.
It is. But if we step back and look at the trajectory of the patient's journey, we have to acknowledge a hard truth here.
Okay, what's that?
These mechanical workarounds, the laxatives, the barrier creams, the peri bottles, they are essential for managing the environment and breaking the trauma cycle, but they do not cure the underlying cigarette paper fragility of the tissue itself.
Right, they're basically just playing defense. To actually stop the tearing permanently, the architecture of the skin has to be fundamentally healed.
Exactly. And for that, we must transition from mechanical protection to medical intervention. We basically move from the bathroom hacks to the pharmacy.
Okay, so what is the medical gold standard for reversing this fragility?
Well, across all the major clinical guidelines we reviewed, including the British Association of Dermatologists and the Euroguiderm guidelines, the unequivocal gold standard treatment is the use of ultra-potent topical steroids,
Ultra-potent.
specifically a medication called clobetasol propionate, typically prescribed at a 0.05% concentration.
So a super strong steroid. But reading through these clinical guidelines, I noticed they are incredibly pedantic about the formulation.
Yes, they are.
Like, why are the guidelines so obsessed with prescribing steroid ointments instead of steroid creams? They really hammer that point home in the text.
It highlights a crucial nuance in dermatology, particularly when dealing with anogenital skin. If we break down the guidelines' reasoning, it all comes down to the chemical composition.
Okay.
Creams are water-based formulations. Now, if you have a water-based product sitting on a pharmacy shelf at room temperature, it's basically a breeding ground for bacteria and mold.
Yikes. So they have to fix that.
Right. So to prevent that, pharmaceutical companies have to pack creams full of chemical preservatives.
And we just established that preservatives, like the ones in wet wipes, are the absolute enemy of inflamed skin.
Precisely. On delicate, deeply inflamed anogenital skin, those preservatives act as intense contact sensitizers. Patients frequently report that steroid creams sting severely upon application, and they regularly trigger contact dermatitis.
So it's literally causing a new rash.
Essentially, yes. It layers a brand new, itchy, allergic rash squarely on top of the existing lichen sclerosus.
What an absolute nightmare for the patient. You finally get a prescription, and the delivery mechanism of the medicine gives you a secondary rash.
It's incredibly frustrating. Ointments circumvent this problem entirely because they are lipid-based. They're formulated from fats and oils like petroleum jelly.
Oh, so no water means no mold, which means no preservatives.
Exactly. Because they lack a water base, they require very few, if any, preservatives, making them far less irritating. Furthermore, the ointment base penetrates the thickened, hyperkeratotic areas of the skin much better.
Wait, I saw that term hyperkeratotic a few times in the sources. What exactly does that mean in this context?
It's just the medical term for when the skin builds up these abnormally thick, hardened, scaly outer layers in response to chronic irritation and inflammation.
Oh, like a callus almost.
Sort of, yeah. And the heavy oils in an ointment soften those hard layers, allowing the steroid to actually reach the active inflammation underneath.
That makes a lot of sense.
Plus, the thick nature of the ointment leaves a superior, long-lasting physical barrier on the surface against environmental irritants.
So the ointment is doing double duty. It's delivering the active medication deep into the tissue while simultaneously acting as a physical shield on the surface.
Exactly. Now, the regimen for applying this ultra-potent steroid is quite specific, and it requires real dedication.
What does the timeline look like?
The guidelines generally recommend a strict tapering schedule. A patient will apply the ointment once daily for a full month, then taper down to alternate days for the second month, and finally down to twice weekly for long-term maintenance.
You know, there is a reality check tucked away in the sources that I think is vital for anyone listening to this who might be dealing with this.
What stood out to you?
The timeline of healing is not instantaneous. The itch and the acute burning might start to fade after just a few days of using the ointment.
True. The symptom relief can indeed be rapid as the localized inflammation is suppressed.
But restoring the actual texture of the skin, thickening it back up so it genuinely stops tearing like cigarette paper during a bowel movement, that can take 3 entire months of consistent daily treatment.
Yeah, people underestimate that. It takes significant time for the skin cells to regenerate and for the underlying collagen structure to rebuild itself normally once the immune system's attack is halted.
I have to admit my own confusion when reading this section of the guidelines, though.
How so?
Well, aren't steroids famous for thinning the skin? Like, if you use a strong steroid cream on your arm or your face for too long, the skin gets noticeably thin, fragile, and easily bruised.
Right.
If the LS skin is already thinned out like cigarette paper, isn't slathering an ultra-potent steroid on it for 3 months basically pouring gasoline on there? How is that not dangerous?
That is easily the most common paradox patients grapple with, and it's a completely logical fear to have, but it stems from a misunderstanding of what is actually causing the thinning in this specific disease state.
Okay, lay it on me.
In lichen sclerosus, the skin thinning, the severe atrophy, is caused by the disease's specific autoimmune inflammation. The disease itself is literally destroying the skin's structural integrity from the inside out.
So the disease is the thinning agent, not the medicine.
Exactly. The ultra-potent steroid acts as a highly targeted strike against that specific destructive inflammation. By halting the immune system's attack on the tissue, the steroid actually gives the skin the breathing room it desperately needs to heal.
Wow.
Instead of thinning it further, the steroid suppresses the destructive process, allowing the skin to rebuild its normal thickness and elasticity.
That completely flips the script on how we casually think about steroids. You are using a heavy-duty steroid to prevent the thinning by stopping the microscopic attacker.
It is rescuing the tissue, not degrading it.
Okay, so let's follow the patient's journey to the next logical phase. Let's fast forward 3 months. The patient has done everything asked of them. They have soft stools thanks to the diet and laxatives. They've utilized the barrier emollients in the peri bottle. They've faithfully applied their clobetasol ointment.
A model patient.
Right. And the dermatologist takes a look and says, great news, the skin is completely robust. No more cigarette paper. But, and this is a big but, the patient sits down on the toilet and they still experience terrible pain and cannot comfortably pass a bowel movement. If the hardware is completely fixed, why does it still hurt?
We are now looking at a deeper physiological issue that the clinical guidelines specifically call out for clinicians to watch for. Think about the timeline we just laid out.
Okay.
A patient, perhaps a child, may have suffered from chronic pain, tearing, and bleeding during every single bowel movement for months, sometimes even years, before getting a proper diagnosis and achieving skin healing.
And it's just a massive amount of trauma conditioning for the body to absorb.
Over that prolonged period of suffering, the central nervous system learns to inextricably associate the act of defecation with agony. It constantly anticipates the pain.
Right.
And as an involuntary protective defense mechanism, the pelvic floor muscles, that complex web of muscles that control the release of the bowel, they clench up tight to prevent the painful event from happening.
It's like flinching right before you get a shot at the doctor's office. You know the needle's going to hurt, so your arm tenses up. But in this case, your internal muscles get stuck in the flinch indefinitely.
That's a great way to describe it. The medical term for this state is pelvic floor hypertonia. The muscles are locked in a state of chronic high tension.
So even if the skin is beautifully healed and elastic, thanks to the steroid ointment, the muscles underneath the skin are acting like a closed vault door.
Exactly.
They are causing a physical roadblock that completely mimics the original constipation. You still can't pass a stool smoothly because the exit door simply refuses to open.
This is a critical juncture where clinical awareness is paramount. If a doctor sees a healed patient who still complains of constipation and pain and simply prescribes, more laxatives or higher doses of steroids, they are completely missing the mark.
Because the skin is fine?
The skin is fine, the stool consistency is fine, the physical hardware is repaired, but the nervous system software is running a trauma loop.
So if this is a muscle memory and nervous system issue, I assume this requires some sort of targeted physical therapy. How do you even go about rehabilitating a pelvic floor to fix that software glitch?
The guidelines heavily advocate for a multidisciplinary approach at this stage. When a clinician identifies pelvic floor hypertonia, the patient needs a referral to a specialized pelvic floor physiotherapist.
What does that physical therapy actually look like in practice?
Well, it involves several modalities. First, manual therapy, where the physiotherapist physically works to release the deep tension in those specific muscle groups, much like working a knot out of your shoulder.
Makes sense.
But the most crucial element is often biofeedback.
Biofeedback. How does that work for these specific muscles?
It is fascinating technology. The therapist uses small external sensors placed near the pelvic floor muscles that measure the electrical activity of the muscles.
Right.
Those sensors are connected to a monitor. The patient looks at the screen and can physically see a visual representation of their muscle tension, usually a graph or a moving line.
So they can see what they're feeling.
Exactly. Because the clenching has become subconscious, the patient often doesn't even realize they are doing it.
Mm.
The screen shows them that their resting muscle tension is sky high.
Wow.
The therapy involves guided exercises where the patient actively focuses on relaxing the area, and they watch the line on the graph drop in real time.
So it's actively rewiring the brain-body connection.
It is. It's teaching the nervous system how to consciously let those muscles relax during defecation again.
That is incredibly profound. It's a truly holistic view of medicine. You start with the localized dermatological skin condition and autoimmune disease, and it ends up temporarily rewiring the patient's musculoskeletal system and nervous system.
Yeah, it proves that you cannot simply treat the skin in isolation. You have to trace and treat the ripple effects.
It really highlights the deep interconnectedness of human anatomy. A chronic trauma to the surface layer profoundly impacts the mechanics of the deep tissue underneath.
It really does.
So, synthesizing everything we've mapped out on this journey, managing perianal tearing and lichen sclerosus is a complex, multi-front battle.
Absolutely.
It requires softening the payload internally. It requires physically lubricating and protecting the exit site with fridge-cooled emollients and swapping harsh toilet paper for peri bottles.
Yep, modifying the routine.
Right, and it involves reversing the skin's fragility with ultra-potent steroid ointments, understanding that the medicine is rescuing the tissue, not thinning it. And occasionally, it requires dedicated physical therapy to unclench traumatized muscles that have just forgotten how to function normally.
And if we connect all of this to the bigger picture for you, the listener, the most important takeaway from this stack of medical literature is validation.
Yeah, validation is huge.
If this is a struggle you are facing or someone you care for is facing, it is a documented mechanical medical issue. It has highly specific, incredibly effective clinical guidelines for treatment.
It's not in your head.
Exactly. It is not something you are making up. It is not your fault. And most importantly, it is a solvable problem that no one should have to suffer through in silence.
The roadmap to a pain-free bathroom visit absolutely exists. But before we wrap up this deep dive, I want to leave you with one final provocative thought. It goes back to that strange, lingering anatomical thread from the sources that we mentioned at the very beginning.
Oh, the mucosal boundary line.
Yes. We learned that lichen sclerosus creates devastating fragility on the perianal skin, the outside layer. It wreaks absolute havoc there. Yet it rigidly, stubbornly refuses to cross the threshold into the internal mucous membranes of the anal canal. It marches right up to the border and it just stops.
It acts as an impenetrable immunological red line.
Which raises an incredible question for you to ponder. If lichen sclerosus is driven by internal autoimmune factors or genetics flowing through the entire body, what is it about that invisible microscopic border between our outer skin and our inner mucous tissues that completely stops this disease in its tracks?
Right, like what specific biological shield does the mucous membrane possess that the outer epidermis lacks?
What secret does that transitional tissue hold? If researchers can figure out why that internal tissue is completely immune to lichen sclerosus, could they reverse engineer that immunity and unlock the ultimate cure for the skin on the outside?
It's a fascinating mystery.
It really is. Until our next deep dive, keep questioning the world around you. And remember that sometimes the most profound medical insights come from the places we are most uncomfortable talking about.